Welcome back to the second part of chapter 28, and that's pregnancy and human development. We're going to now begin our second part from embryonic development. Remember, recall that from the first segment or the first part of chapter 28, we um, we pretty much looked at um, fertilization. We looked at the development of the zygote. We looked at the traveling of the zygote after fertilization, and then the implantation of the blastocyst, and then the formation of the placenta, the development, and then finally into the development of the three germ layers, which is actually starting on to gastrulation. So we're now going to move into the embryonic development, starting from what are the simple events that are happening in the gastrulation. The, during the gastrulation, we have pretty much the formation of the different derivatives, the ectodermal and the endodermal, as well as the mesodermal derivative. Pretty much in in the ectodermal derivatives, you have the formation of the epidermis, the hair, the nails, the glands of the skin. Then you have the brain and the spinal cord. And pretty much, don't forget, we have also the development of the neural crests and all the derivatives. For instance, your cranial, spinal, and sympathetic ganglia, and all of the associated nerves, the chromaffin cells of your adrenal medulla, and the pigment cells of the skin. Meanwhile, here in the endoderm, you have the epithelial lining and glands of the digestive and the respiratory tracts. All of this will start its development also. And then finally, the rest of them is all coming from the mesoderm. Coming from the line of the notochord, you have the nucleus pulposus of the intervertebral discs. Then the line of the somites, you have the sclerotome, the vertebrae, and the ribs. You have the dermatome, you have the dermis of the dorsal body region, and then you have the myotome, which happens to be the trunk and the limb musculature. Then from the line of the intermediate mesoderm, you have the development of the kidneys and the gonads. In the line of the lateral plate mesoderm, your somatic mesoderm gives rise to the parietal serosa, the dermis of the ventral body region, the connective tissues of the limbs, the bones, the joints, and the ligaments. And finally, the splanchnic mesoderm, you have the wall of the digestive and the respiratory tract except the epithelial lining, and then the visceral serosa, the heart, and the blood vessel. In a nutshell, this is actually just how it looks, and it would look simple by the way it is actually presented in this particular list and this particular diagram, the flow chart itself, but it is not as simple as that. And because this is not a subject in embryology, I will just leave it at that. I just want you to know that you're going to be tested on what the fate is of the three germ layers. Pretty much, I can we can ask you in your final exam, pretty much what gives rise to the ectoderm, the epithelium of the ectoderm, what is actually going to be the fate of the mesoderm or the fate of the ectoderm, things like that. All right, but we are only going to be as broad as the way I presented it to you or the way you're going to see it in this particular video, but not necessarily any more it's not anymore going to be more detailed than what you're going to see today. And here's actually, if you're going to be more visual from the gastrula, this is actually what happens to the ectoderm, the external layer, and it will become the skin cells of the epidermis, the neurons of the brain, and the pigment cells. And your endoderm, which is the internal layer, it will give rise to the lung cell, the alveol, which is actually the alveoli, your thyroid cell, and your pancreatic cells. Then you have also your mesoderm. This is the middle layer. It will become the cardiac muscle, the skeletal muscle, the tubule cell of the kidney, the red blood cells, and the smooth cells in the gut. So let's take a look at the fetal circulation, or what's happening, or how does the fetus in circulation would be circulating its own blood. The first blood cells in utero arise in the yolk sac by the end of the third week. So the yolk sac becomes, or actually gives the fetus its own red bloods or its own blood cells, and pretty much uh, an embryo would have a system of paired vessels. The two vessels forming a heart have fused and bent into an S shape by this age, and the heart would beat something like 3.5 weeks in utero. Now, there's unique vascularization that is seen only during the prenatal development and are pretty much like occluded at birth, which means they will stop functioning at birth. And this will include the this will include, as part and parcel of the umbilical arteries and vein, three vascular shunts. First, you have the ductus venosus. The ductus venosus would bypass the liver, and the umbilical vein drains into the ductus venosus, which empties into the inferior vena cava. Then you have, that's actually shown here in the diagram, you have ductus venosus, pretty much. This bypasses the liver, and the liver it's because the liver is not fully functional yet at this moment. Then you have also the foramen ovale. Your foramen ovale was taken up when you were doing the heart. It is an opening in the interatrial septum that bypasses the pulmonary circulation, because at this time the um, the the lungs of the fetus is not yet working. And then the ductus arteriosus, which bypasses the pulmonary circulation also. Pretty much the pulmonary trunk drains directly into the ductus arteriosus, which drains into immediately into the aorta. It will be bypassing the lungs, and all of these are pretty much like ways by which the fetal circulation would bypass the organs that is not yet really functioning at the time in the utero, because their needs for the organ is actually supplied by the mother. So we start right here. Pretty much, the placenta is the lifeline between the mother and the baby. The ductus venosus is actually that part of the umbilical vein. This is actually your ductus venosus right here. That part of the umbilical vein that is carrying oxygenated blood from the placenta. It passes the liver, because some blood will go to the liver, but most of them will be shunted because at this time the liver is not fully functional yet. Okay, then if it goes, it is shunted to the inferior vena cava by the ductus venosus. Then the blood it goes right into the right atrium. This is your right atrium right at this point. Blood goes from the inferior vena cava to the right atrium, as well as some deoxygenated blood coming from the superior vena cava, and is now going to be mixed together. And it goes into from the right atrium. It should go into the right ventricle, but right through there you have already a hole, which is the foramen ovale. Blood is now shunted from the right atrium to the left. So it goes straight to the left atrium by the foramen ovale. And the blood will bypass the lungs. Why? Because the lungs is not functional yet, and there's no need for the blood to stay there. Now, there's a question here: how can blood be shunted from the right atrium to the left atrium? It's actually just the pressure, because there's actually no other way by which it can actually flow. There's also the right ventricle here that's actually that would have pressure for blood. You cannot anymore push the blood there, and the blood that's coming from the right ventricle will actually be going into the pulmonary trunk and then into the ductus arteriosus. So the pressure difference actually makes it, and blood flows from high resistance into low resistance. So the lungs itself is high resistance, and so the blood does not want to go into the lungs. So you have a lot, you have blood inside there or fluid inside there. So there is another one which is your ductus arteriosus. The ductus arteriosus, right at this point here, the blood here is shunted from the pulmonary artery. This is your pulmonary artery or the pulmonary trunk, and is actually shunted into the aorta by the ductus arteriosus. The aorta, the aorta will be carrying, the aorta will now be carrying mixed blood, and it's now pretty much being, what do you call this, being pushed out to oxygenate the fetus. And where is the oxygen coming from? Well, actually, the oxygen is coming from the placenta, which is actually coming from the umbilical vein, which is coming from the mother. And then the umbilical arteries will return all of the blood that pretty much circulated into the fetus. It will now be returned to via the placenta back to the mother. So it picks up nutrients and oxygen from the mother. It goes back to the placenta to be oxygenated again. And here you have the special fetal structures that is um, being used by the fetus in their blood circulation, and the shunting, okay, the bypassing of all the organs that are not being used yet. So let's take a look at more on the embryo. So pretty much what happens during the embryo at the time of its development. At the end of its the embryonic period from weeks 1 to 8, the bones here begin to ossify, and the skeletal muscles are well formed and they are already contracting. The kidneys, we call it the mesonephric kidneys, are developing, and the gonads are already formed. The lungs, the digestive organs, are pretty much attaining their final shape and body position. The blood delivery to and from the placenta is actually constant and is very efficient. The heart and the liver bulges on the ventral surface. All this is happening in an embryo that is about roughly less than an inch from crown to rump, and it weighs about only 2 grams, about 0.06 of an ounce. That's how little our little guy is. And here you have a picture of a developing fetus, um, 3 months, and there it's about 6 centimeters long. And here's another fetus that's about late in its 5th month, and it's about 19 centimeters long. So on the fetal period, about weeks 9 up to 38, there's actually like time of rapid growth of body structures that establish in the embryo. The fetus grows to about 14 inches and would actually have a weight of about maybe 3.2 kilograms, or about up to 7 pounds. Well, not all of them will be 7 pounds, but up to 7 pounds. There are changes in fetal appearance, and it's actually dramatic within this stage. There's greatest amount of growth that occurs in the first 8 weeks. And when the embryo grows from one cell to about an inch long, you could see the difference, but you could see more after that. And here is actually a good picture of the development of the events of the fetal period, which you could actually work on and see and take a look in your review. This is a very good review sheet. Here you go again, up until 9 months. So let's now leave the fetus now. Let's leave the baby, and let's take a look at the effects of pregnancy on the mother itself. Now, the mother or the looks of the mother or the body of the female changes. Now, before conception, the uterus is the pretty much the size of a fist and resides in the pelvis. The mammary glands and structure is pretty much largely rudimentary. In about 4 months, the fundus of the uterus is halfway between the pubic symphysis and the umbilicus. It's actually growing. And by 7 months, the fundus is well above the umbilicus. You could see already that the tummy is already like protruding at 7 months. And at 9 months, the fundus reaches the xiphoid process already of the sternum, and the glandular tissue of the mammary gland here is fully developed. So you know that the uterus is actually expanding, which to give way to the development of the fetus, and it occupies most of the abdominal cavity. The ribs will flare and the thorax will widen. Sometimes lordosis occurs with a change in the center because of the change in the center of gravity. Relaxin is a hormone that the female produces, which causes the pelvic ligaments and the pubic symphysis to relax and to ease the birth passage. There's going to be like a weight gain of approximately about 28 pounds, and it's usually seen commonly, okay, when most especially during the first baby, because the woman or the female doesn't know yet how to control herself. But usually in the succeeding pregnancies, usually the woman will learn exactly how to control her weight. Now, the reproductive organs pretty much would become engorged with blood. You will have what you call a Chadwick's sign. The vagina will develop purplish hue. The breast will enlarge, the areola darken. There's going to be pigmentation of the facial skin, and which you call cloasma. And there are also changes that will happen in the metabolism, the effects of because of the effects of the placental hormone. The human placental lactogen, and also called the human chorionic somatomotropin, is actually a hormone that stimulates the maturation of the breast, fetal growth, and glucose sparing in the mother. Pretty much, we are reserving the glucose because we are reserving the glucose for the fetus, and may cause, oftentimes cause gestational diabetes mellitus. The parathyroid hormone and vitamin D levels stay high throughout pregnancy to ensure adequate calcium for fetal bone mineralization. Now, physiologic changes would include pretty much in the gastrointestinal uh, system, morning sickness, which is believed to be due to the elevated levels of the human chorionic gonadotropin, and as well as estrogen and progesterone. Then the female will have heartburn and constipation. And in the urinary system, there's increased urine production due to the increased maternal metabolism and tissue waste. The pregnant woman would experience also frequent urgent urination and stress incontinence, maybe because the bladder is being compressed by the growing fetus. Now, in the respiratory system right here, the estrogens may cause nasal edema and congestion. Therefore, the tidal volume increases and there's going to be difficulty in breathing. It can occur later in pregnancy. Um, in a cardiovascular system, the blood volume increases by about 25 to 40% to safeguard against blood loss during childbirth. This would pretty much like increase the cardiac output by about 35 to 40%, and to propel pretty much a greater volume around the body. The venous return from the lower limbs may also be impaired, resulting in varicose veins, and there are some undifferentiated fetal stem cells that can enter maternal circulation and can integrate into maternal tissue. The consequences to the mother of this is really relatively unknown. So pretty much right here, in this particular uh, picture here, you can already see the summary of the things that's going to happen to a pregnant woman and its effect, the effect of pregnancy to a female. Now let's take a look at some homeostatic imbalance. Teratogens. These are factors that cause severe congenital abnormalities, even fetal death, if potentially harmful substance cross the placental barriers and enter the fetal blood. Pregnant women who drink alcohol may cause the fetus to become inebriated, but fetal consequences may be much longer lasting and may result, most especially in a syndrome which we call the fetal alcohol syndrome. And an example, and children who are actually um, with alcohol fetal syndrome or fetal alcohol syndrome is typified by microcephaly. They have a small head, they have intellectual disability, and they have abnormal growth. On the other hand, alcohol is not the only thing that could negatively affect a fetus. Nicotine, smoking, hinders oxygen delivery to the fetus, impairing normal growth and development. Many drugs, including anticoagulants and antihypertensives and sedatives and others, can also affect the fetus, as well as maternal infection, such as rubella, which is actually German measles, can also cross the placenta and can even kill the fetus. So, what about labor? So, we're now in labor. The fetus now is getting ready to come out. The fetus determines its own birth date. During the last few weeks of pregnancy, an increase in cortisol releasing hormone from the fetus, so from the fetal hypothalamus, would lead to an increased release of fetal cortisol. This increase in fetal cortisol begins in a positive feedback loop with the placental CRH. The release of placental CRH will increase, and more cortisol and even more pretty much will also be released, leading to a rapid rise in fetal cortisol. And this rapid rise in fetal cortisol levels would trigger the maturation of the fetal lung, increasing the production of surfactant, which is pretty much like the things that we need in order to be able to breathe properly. If the fetus will not be able to produce enough surfactant, by the time it's actually going to pretty much like be born, and it will not be able to breathe. So the fetus will need to have enough surfactant in order to breathe on its own. Now, the increased cortisol, also the increased fetal cortisol, also leads to a rapid increase in estrogen. There you go, estrogen production by the placenta. Increased estrogen together with decreased progesterone would have three effects. First, it prepares the cervix for dilation. The synthesis of prostaglandins and its receptors would increase, which plays a role in the thinning and the softening of the cervix. The second effect will be it prepares the myometrium of the uterus for contraction. Increased synthesis of actin and myosin enzymes will will be will happen for a more forceful contraction. This causes the formation of gap junctions between the uterine smooth muscle cells. It antagonizes the calming effect of progesterone, and then it leads into what we call Braxton Hicks. This Braxton Hicks contraction is also called false labor. It increases the sensitivity of the myometrium to chemical messengers that cause it to contract, pretty much, which eventually will lead to the um, the cervix stretching and oxytocin um, being released. And when oxytocin is released and prostaglandin is released, you are going to have with the increased production of its receptors by the myometrium, these prostaglandin will initiate the rhythmic contraction, and oxytocin would increase the contractile force. So this positive feedback mechanism will occur. So it's going to be, it's oxytocin now is going to be released in large amount. There's greater distension of the cervix, which will pretty much cause more of this oxytocin and prostaglandin to be released, a greater contractile force, and then causing the release of the fetal fibronectin adhesive protein that holds the fetal maternal tissues together, and it will loosen its hold eventually at this point in time. Now, antiprostaglandins, such as ibuprofen, can inhibit the early stages of labor. So pretty much you can see the events that would pretty much lead to labor, and this series of events would help in expelling the infant from the uterus. And here it is again. Okay, you have after that, well, you have already oxytocin, and that's actually causing the contraction. There's going to be early dilation. The baby's head now is engaged in this particular picture, and its widest dimension lies in the left-right line of the pelvic outlet. And you have the late dilation. This is where the baby's head rotates. So the widest dimension is in the anteroposterior line of the pelvic outlet. Dilation is actually almost complete here. And then finally, the expulsion, the baby's head extends as it is actually delivered. And then finally, the baby is delivered, and now this is the placental stage. After the baby is delivered, the placenta detaches and is removed. So the baby is out and is ready for its life outside. But of course, it's going to be dependent on its mother. There's a lot of adaptation that the baby needs to pretty much like get into. It cannot leave on its own yet. It would need the help of its mother. So the neonatal period is about 4 weeks immediately after birth. Birth pretty much is a shock to the baby. So physical status is assessed within 5 minutes after birth. And we use what we call the APGAR score. And pretty much we give 0 to 2 points for each. And that will be A is for appearance, P is for pulse rate and heart rate, and G is for grimace, and then A is for activity, and R is for respiration. So this all points to a score of pretty much like about between 8 to 10, and you're going to have a healthy baby. So respiratory adaptations, pretty much, there you go, your respiratory adaptations. Once your carbon dioxide is no longer removed by the placenta, the baby now has to pretty much like adapt on its in the removal of its own carbon dioxide by breathing it out by itself. So right here, the initially the carbon dioxide is going to rise and will cause what you call central acidosis. This will stimulate the respiratory control. It will center to trigger the first inspiration. This requires tremendous effort, okay, and airways are tiny and the lungs are collapsed. And surfactant in the alveolar fluid would help reduce the surface tension. The respiratory rate at this point in time is about 45 per minute, and in the first 2 weeks, this respiratory rate will continue to decline until it's normal. This will keeping the lungs inflated at this point in time is very difficult, most especially for premature infants, which is about less than 5.5 pounds and maybe less than 7 months in age, most especially when it is not yet complete or it's not yet really producing enough surfactant. Surfactant production occurs in the last months of prenatal life. So the preemies usually require respiratory assistance until their lung would mature. Now, there is actually what we call transitional period. These are unstable periods lasting about 6 to 8 hours after birth. So this is where there are alternating periods of activity and sleep. The vital signs may be irregular during these particular time, and the baby gags frequently as it regurgitates mucus and debris. This usually stabilizes with waking periods occurring every 3 to 4 hours. So the baby is getting used to the adaptation, and all of these cardiac adaptations pretty much will close up so that it will actually go into its normal blood circulation. The occlusion of several fetal blood vessels, the vascular shunts, in the pretty much it will actually close up. In a newborn, the umbilical arteries and vein constrict and would become fibrosed. The proximal umbilical arteries persist as a superior vesicle arteries to the urinary bladder. The distal umbilical artery becomes the medial umbilical ligaments. The umbilical vein becomes the round ligament of the liver, which you call also the ligamentum teres in your anatomy of the liver. The ductus arteriosus, the ductus venosus, you remember your ductus venosus, is converted into the ligamentum venosum. And you have the pressure changes from the infant breathing can cause all of these pulmonary shunts to eventually close. The foramen ovale becomes fossa ovalis. Um, it's not really so quick. It can take up to a year after birth, but it's not really going. The opening is not really that that wide as to pretty much like cause harm to the baby. The ductus arteriosus becomes ligamentum arteriosum, and but except for the foramen ovale, which can take up to a year to completely close, all shunts will be closed within 30 minutes after birth. A failure of the ductus arteriosus or foramen ovale to close would lead to congenital heart defects. So, pretty much towards the end of the pregnancy, the hypothalamus is stimulated to release the prolactin releasing factor. Uh, and pretty much this is actually released by the placental estrogens, by the progesterone, and by the human placental lactogen. The, uh, the prolactin releasing factor stimulates the anterior pituitary to release prolactin within 2 to 3 days later, and true milk production will begin during the 2 to 3 days. Therefore, immediately after the baby is born, the mother will not be able to feed the baby with true milk. During the 2 to 3 day delay, well, true milk would eventually come in the mammary gland in the form of colostrum, which is really not even true milk. It is a yellowish fluid that has less lactose but more protein and vitamin A and minerals than true milk itself, as well as almost no fat. It is also rich in immunoglobulin antibody A, and this IgA is resistant to digestion. Remember that immunoglobulins are proteins, and you probably say, well, if it is actually a protein, it could be digested by in the guts of the infant. No, it's not. It is resistant to digestion, so it may protect the infant against bacterial infection. Some may be absorbed into the bloodstream to provide broader immunity. So prolactin would wane, the release of prolactin would wane after birth. So lactation is sustained by the stimulation of the nipples of the mother during when the baby will suck the milk. Suckling stimulates the mechanoreceptors in the nipple, causing the afferent impulses to be sent to the hypothalamus, triggering the release of the PRFs. The anterior pituitary will release the prolactin and stimulates milk production. And pretty much, let's take a look at this milk production chart that is right here in front of us. Okay, so that's like what I mentioned there, the mechanoreceptors. The It's initiated when the infant would suck into the nipples of the mother, and that will eventually cause the hypothalamus to produce PRF, and the anterior pituitary now will be stimulated to secrete prolactin to the blood. Prolactin targets the mammary gland of the breast, and milk production will start. And the same the same token, the same mechanoreceptor stimulus will pretty much like send in the hypothalamus send efferent impulses to the posterior pituitary. Well, oxytocin is actually stored. Oxytocin is released from the posterior pituitary and stimulates the myoepithelial cells of the breast to contract, and this will cause the milk letdown. Milk is ejected through the ducts of the nipples. So it's only a slight stimulus right there in the nipple, and milk is already going to spurt out. So, what would be the advantages of breast milk? Now, the breast milk is really one of the best milk that you can actually give to an infant. It is actually better absorbed. The fats and the iron are better absorbed from the milk, and the milk breast amino acids are more easily metabolized compared with cow's milk. And pretty much it has a host of beneficial chemicals, including IgA. It would have the antibodies. The complement system is there, the lysozyme, the interferon, lactoperoxidase, and these will all be protecting the infant from infection. The interleukins, the prostaglandins, prevent overzealous anti-inflammatory response. You have lots of glycoproteins, which deter ulcer-causing bacterium H. pylori. And there are other advantages, which is it encourages bacterial colonization of the infant's gut. It has a natural laxative effect that helps cleanse the infant's bowel of meconium, which is pretty much a thyroid green black paste containing slough of cells, bile, and other substances. It's helping eliminate meconium as soon as possible and helps prevent physiological jaundice. For the mother, okay, there's also advantages in breastfeeding. Women that are nursing greater than 6 months or longer than 6 months can pretty much like will not sometimes um, will not actually ovulate and therefore would not get pregnant. Okay, and but there are also other things that could happen. Six women who are actually like feeding their babies 6 months, more than 6 months, can lose bone calcium and could be replaced by pretty much like eating more calcium in the diet. Women women may ovulate later when they are nursing, and pretty much there's a lot more, and that's actually like increasing the connection between the infant and the mother. That's actually one of the most important thing. And so I think this is already the last of the slide for the chapter 28, gestation. And we are now going to um, get into one that would not sound like it's part of anatomy, which is actually heredity, and that's going to be the next chapter. I'll see you in the next chapter.